Hey everybody, happy Monday. Welcome to another of the Doctors on Call webinars where we try to answer as many questions and cover some new updates in gastric and esophageal cancers. Tonight we're joined by a couple experts, Dr. Jordan Berlin and Dr. Yelena Janjigian. Probably go by first names if that's all right with everybody. It's just a little bit easier. I want to start off, as usual, by a little bit of a poll question, sort of understanding who's here. So before we get into some of the question and answer, maybe if you can bring up that first poll. All right, so you probably see this on your screen. If you don't know how to use Zoom, I'm sorry. But the question is, what is your current chemo regimen for the people that are on therapy? FOLFOX, FLOT, FOLFOX plus something else like a HER2 drug, FOLFIRI, Taxol and ramucirumab, a clinical trial, or something else. I have to say, over the few of these that I've done, it's been pretty interesting to see the broad representation of therapies that people are on. All right. So looks like about quarter of people are on FLOT. About 30% of people are on FOLFOX in some combination, and then 50% of people are something else. And we see someone in the chat who put in FOLFOX plus zolbetuximab, which of course is one of our newest drugs in this disease. So a lot of people submitted questions tonight. So we're going to just jump in. Just a little bit of housekeeping. Raise your hand. We will get alerted to people that raising their hand, but the people that submitted questions ahead of time, we will try to cover those since they did follow the rules. Anyone who wants to ask a question live, that's certainly welcome. You can also put it in the chat if you don't feel comfortable sharing. And I think we can just get right in. Maybe one more poll question in the beginning while people are still coming in. So I want to bring up the second poll, which has to do about aspects of daily life that are impacted. This is a really important question. So you should see it appearing on your screen. This basically asks, what is the area in your life that is most affected by chemotherapy, or let's just broaden it to treatment in general? Is this energy, appetite, emotional well-being, social interactions, etc.? And while we're waiting for the answers, just a welcome to Dr. Janjigian for joining. All right, interesting. So more than half of people, 56%, said energy level and fatigue was what was most impacted to them by chemotherapy. Second most common answer with a quarter of people was appetite and digestion, and the third was emotional well-being, and nobody said social interactions and relationships. Interesting. I think it's going to be interesting to see all this data over time that Debbie's Dream is gathering. Question, these are available after the recording. Again, the stuff, the advice is not specific to anybody's case. This is general advice, so just, take the recorded answers with a grain of salt. It's not specific medical advice to your case in general. So I'm going to jump right into these questions, and maybe I'll bring this first one to you, Yelena. So this is a question from Hike in Armenia, which asked, patient that's mismatch repair intact, clinically stable, on therapy, I can't tell. Do you recommend next generation sequencing? And maybe just broadly, like, how do you think about incorporating these sort of expanded molecular tests into your practice?
Sure. Well, I think in the United States or uh, institutions where NGS is readily available and the patient is willing and able and it's not associated with extra cost to the patient or the family. I think it's a very useful tool to give us a sense of about the disease biology and how we can perhaps monitor it and target it, especially if we use circulating tumor DNA. For most patients, however, because we use immunotherapy in first-line setting, and because many of our biomarkers are readily available through immunohistochemistry, through protein overexpression, as you know, I think practically NGS does not yield to the, major aha moment, this is what we're using. So largely we use next generation sequencing as a backup tool to understand if there is any later line therapy trials we could offer to the patient, mostly in early drug development in phase 1 or phase 1B, mostly in second or third line. We always talk about strategy for management of metastatic disease and knowing what your next move will be. 3 moves ahead is really the best way to stay focused and to stay ahead of the disease biology. Practically, though, if in a patient who may have, if there's limited resources or tissue availability, and they have to pay for the cost of NGS, I don't know if that's how I would spend sort of those resources.
Yeah, good answer. All right, Jordan, I'm going to come to you with this one. It's interesting, sort of cross diseases. So this is from Lily in Lexington, Kentucky. Otherwise healthy 70-year-old male with MSI high gastric adeno, T3N0, got 12 weeks of ipi-nivo and is about to have upper endoscopy, ultrasound, PET. Um, in these patients, which is kind of a new paradigm, we've seen this new recent New England Journal organ sparing paper. Um, if there is a complete clinical response versus an incomplete clinical response, like how are you thinking through this paradigm?
Well, yeah, if there's an incomplete clinical response, I'd have a tough time not saying, cut it out. But you could continue a little longer and see. I don't have an objection to that if you can get to a complete clinical response. But with complete clinical response, I wouldn't call what we have definitive enough. But I think it's encouraging enough, and I would have no problem with watching and waiting rather than taking him to surgery based on what's happened with other diseases and what data we do have. But I don't know what you think, Yelena, but
Maybe I'll
I
ask
think
you one.
one of the issues we've run into with MSI disease is that we want to believe that it's going to be a clinical response
right.
so much that often we wait too long. And it's actually, in the Andreas Dostorolimab study and many other experiences with this disease, if you don't see a response on the first scan, you probably won't see a very deep complete response, or if the response is just
Well, that's my problem.
suboptimal,
It's
we
that
have
that
the
was not a
data.
non-responsive. It's just not a complete clinical response. So
Yeah,
I at 12 weeks, if you're not there, I'm not sure you're gonna get
I
there.
agree. I would, and I think if the tumor is resectable, that and there's it's possibly if total, complete resection is feasible, I would just do it. Otherwise, chemoradiation would be another option.
Yeah, and I'll take the last one here in the
Well,
chat.
they asked if switching to dostarlimab.
Yes.
I don't see switching from one IO to another would really make a difference.
Yeah,
They're very similar drugs.
I think that's a no. We would not
They're the
generally.
exact same. There's many companies with different anti-PD-1 or anti-PD-L1 inhibitors. We will see data at ASCO with durvalumab, which may also be a new name, but it doesn't mean that it's really any better. A lot of these agents are similar across the board.
Agree, agree. Um, all right, I'm gonna come to you, Yelena, with this one from Lakeville, Minnesota. So this is specific question, but you can answer it a little bit more broadly. So stopgap, which is an intraperitoneal Taxol plus intravenous Taxol study, is an ongoing study, and the person is asking, with stage 4 disease, responded well to chemo. If I needed to somehow get the cancer out of the lining of my bowels, gallbladder, etc., Are you thinking about peritoneal strategies? Maybe I'll just broaden the question a little bit.
It's a tricky conversation to have, and we have these conversations with our patients all the time. And I think the best you could do is have a sit down with a surgeon who is a trusted surgeon. Perhaps your doctor could refer you to someone, or if you reach out to us, we'll make a referral. You need to sit down with someone who will have a honest, but also very measured conversation with you, and would be the type of surgeon who's willing to not operate. Because in a patient who's responding to systemic therapy, most of the benefit is from systemic therapy, right? And the reason why some of these studies show outlier benefit is because they're hyper-selecting patients who may actually do fine with just systemic therapy, may have good outcome with just, by systemic therapy, I just mean good old IV chemotherapy. Now, other situations where we would consider intraperitoneal therapy, sure. Will it be the cure? And I want to be positive, and I've never met you, so it's hard to be sort of too direct without, on the web cam on Monday night. But I have not seen a patient cured definitively with these therapies. I think what we've seen, and what I've seen, is where patients may have had this, disease-free, chemotherapy-free period, which was a very nice holiday, and it gave them a sense of, that they were under control and cured without any treatment. But all of these patients eventually recur. And I'm sorry to say that right now, all of our best treatments are still the same chemos we can give IV. And until we come up with a unique biologic or theranostic or otherwise targeted agent that can address the specific problem in peritoneal disease and the biology that drives it, we will be in the same problem, which is systemic recurrence.
Yeah, I'm gonna sort of spin this over to you, Jordan, for the next question, which is also in the chat. But we know peritoneal disease can sneak up on people, hard to see on imaging, etc. So someone who's post total gastrectomy in general, let's say a stage 3 patient, beyond sort of standard surveillance imaging, are you doing anything? Are you incorporating MRD testing, ctDNA, etc.?
I am not incorporating ctDNA. I know others probably are. One of the problems is that if we have a ctDNA positivity, but we can't find anything on imaging, I don't have any data that starting therapy at that point is going to do something better for a person. It doesn't mean that the cancer is not coming back, but if I don't have any data to suggest that that's going to necessarily help, starting somebody on something sooner, it just could give you side effects at a sooner time point in life. And you look at the second question in the survey, and you can see that treatment affects people's lives. And so
Yep.
if I don't have proof that's going to make them live longer, better, or something like that, an asymptomatic person who just has a blood test that's abnormal, it's hard for me to recommend treating.
Yeah,
By the
I
way,
agree.
just so you know, the Stopgap 2 study is getting close to opening, which will be a nationwide, it won't be open everywhere nationwide, but it'll be open at several sites around the nation.
Yeah, I think a good, well-designed, thoughtful study. Yeah, I agree with you. I think, we like to collect this information and understand ctDNA kinetics and risk, and it's clearly a prognostic feature. But I agree, we don't yet have enough data to clearly act on it. Lawrence, I want to recognize your hand, so if you want to come live and ask your question, feel free.
Hello, good evening, everyone. Hi, good to see you, Dr. Klempner. Hi, doctors. So, I have a long story, as I have my share before. I was initially diagnosed with stage 2B, back in 4 years ago, 2021, and received the chemo flot before and after the surgery, and I removed my 70% of my stomach. Everything was okay until last year. I found out this recurrence with nodal lymph nodes recurrence with both involve D2 and D3 area nodes. I started my treatment since last year, April, so now it's been a little bit over a year. And then fortunately, it has been responding very well. And then, those nodes back in normal in size, and then the biopsy came back as negative. However, my latest ctDNA increased from 8 to 30 this time. And then they don't see any other signs of recurrence. No, nothing new popping up. But then, sorry. But then I have a left femur on the bone lesion, grows from 0.4 centimeter to 1.2 centimeter, and then and it's showing uptake on the recent bone scan. And these 3 spots actually was already there last year before I was diagnosed for the recurrence, and then they were suspicious for the bone mass since last year. Very interesting. A radiologist noted this lesion actually was already visible on 2021, which was 4 years ago, the scan before my initial surgery. Given the fact that I was off treatments for a little bit over 2 years, and now it's unclear is these are truly bone mass or not, because the rib lesion has been stable, but then the femur lesion has growing from 3 times from last year, from 0.4 centimeter to 1.2 centimeter right now. So just think about what should be next step, and then are these bone mass real or not, and contributing to the rise of ctDNA or someone else.
Yeah, well, you've obviously educated yourself very well about your own course. Thanks for the clear story. Yelena, I'm going to come to you with maybe talk a little bit about biopsy role and what your thoughts are. Obviously, this is a little bit of a specific question. You might be on mute. It's the microphone button if you want me to teach.
Yeah. Can you hear me?
Yeah.
Well, if you're such a smart ass, maybe you should answer the question. Go ahead.
No, I was going to ask if biopsy was something that was discussed with you for this enlarging. Sounds like it's one site that's enlarging in the femur. Oh, sorry. That was to you, Lawrence. If they discussed the biopsy with you.
Oh, they were saying the biopsy is kind of risky, and even though the biopsy came back negative doesn't mean it is negative, because it is a bone lesion, and then it's kind of a little bit risky. That they thought about, they are thinking about doing it, maybe yes or maybe no, but then they rather to do a PET scan right now to see if they are continue lining up on the PET scan, comparing with the bone scan, the CT scan I just had, and then see and go from there. And I'm repeating another ctDNA within 2 weeks and see how it goes.
Yeah, the PET scan sounds very reasonable to me from what you're describing. I mean, it certainly is a little bit suspicious from what you've described about, a slowly growing spot in the context of a rising ctDNA. But agree, PET scan to guide potential biopsy would make some sense.
Yeah.
Mm.
And ultimately, it sounds like, Lawrence, you don't have any cancer-related symptoms, or is there a spot painful?
My rib area has always been on and off, like discomfort, a little bit of pain, but it's been there for several years. But my left femur, I don't really feel anything at the moment.
Yeah, I mean, I think the biopsies, and I think to what Sam was asking, biopsies are plus minus. If there's a convincing evidence that something is wrong and the patient is having symptoms, or if there's an area that is quite concerning, and then you sample it and it's non-diagnostic, it almost doesn't convince you. It's just you realize that biopsies are not foolproof, and it's like, going into a bag of apples is trying to find a rotten apple blindfolded, right? So you may miss it. And so I think it's the whole picture together. Typically what I use to try to make a determination. I think circulating tumor DNA is useful, but maybe unreliable. Usually it's the time on prior therapy because we know when the risk of cancer progression on a certain line of treatment may be at the highest. So it's putting all these pieces together. And most importantly, how are you presenting clinically? Sometimes, I see patients from all over, and probably one of the common mistakes people make is switching therapy too soon without any frank evidence of progression. Especially if you're feeling well and if there's no symptoms to suggest that the cancer is worse. I think I would caution you because it feels like we're giving you good advice, but in reality, these curbside consults are not good. You need to have a sit down with a doctor where a radiologist goes through scan by scan by scan and with a fine-tooth comb, really, reviews everything because the person who knows you the best is the person who's been taking care of you for the last year. And we're just advice givers and, not even good at that because it's, I need to see the scans. I need to see the patient before I make the different. So these type of platforms, I think, are best for, as Dr. Klempner was saying, big concepts, general sort of data and how, to steer sort of overall trajectory of where the field is going.
Thank you. I did talk to the radiation oncologist, and she was saying,
radiologist. There's two different, right? Radiation doctors radiate, radiologists diagnose. We need
radiation oncologist.
Right.
I did today.
You don't radiate until you decide what you have, right? So I'm asking for, it's slightly different questions, but
I think, Lawrence, the big issue is that there's no way that we could tell you exactly what to do and know that we're telling you the right thing because we don't have the scans in front of us. We don't have all the information in front of us. And it would be unfair for us to start making guesses that we really aren't capable.
Yeah. But I mean, if in general, if their lesions were there 4 years ago, wouldn't we expect more in progression for the bone mass in general? If that's
Cancer varies a lot and it does a lot of weird things. So we can't guarantee, and we can't guarantee that you didn't have something. There's this weird thing called the Schmorl's node, and it just happened to have shown up right where the Schmorl's node is. I can't guarantee that what was there 4 years ago was actually what we're seeing right now, or something happened to have grown there. Plus, we don't know for certain that this is cancer based on what you've told us. So it's really hard for us to start making guesses about your specific case without the full information. It wouldn't be fair for us to do that.
Yep.
Right? I know that's what you really want us to be able to do, but we're also imperfect and we can't make guesses based on partial information without looking at the scans. And in this case, it's bone, so I would need a radiologist sitting with me going over the scans. And me just looking at the scans wouldn't be good enough.
Yeah, I agree.
It's hard, and we really want to be able to answer your question, but it's not going to be possible.
I understand. Thank you. Yeah.
Oh, great questions. Jordan, I'll start with you, and then I'm going to come to you, Yelena, about this question because you spend a lot of time thinking about this. But broad question from Rita in New Hampshire, which is, what are the newest treatments and technologies in patients with advanced gastric cancer? Jordan, maybe mentioned any strategies or particular targets that you're most interested in, and then Yelena, same question.
Well, yeah. So Yelena brought up earlier that we've really not found the molecular targets that other diseases have had, but we've had some interesting ones with Claudin, with HER2, which is a molecular target, and with MSI high. Those are all areas that we do have targeted or therapies that do work particularly well in or are very helpful in, and Yelena has actually run most of the studies. The truth is that that those are the big areas I think that we have right now, but future areas may come along as we're learning new things all the time. I mean, Cloudin wasn't even something I thought about 5, 6 years ago. So um, I am going to have to run for a moment. I've got my a smoke detector that's beeping low battery,
Oh,
and my dog is ready to pee on the floor. So I apologize. I'll be right back.
Important, important. Yelena,
There's a problem with doing things at home.
yes, no, I'm surprised that you haven't seen a cat on my end either. Yelena, so maybe a little bit different question, which is you're obviously about to have a big data set in non-metastatic disease. Maybe talk about like spaces where you think we need to do more. Is it non-metastatic? Is it late line? Is it pushing on frontline combinations?
yeah. I think early stage disease will be huge in next 2 or 3 years. I mean, because I have to say, so many more clinicians, patients, but also, industry is so interested in going into that space. And I think that's a great space for us to be in because we can cure patients, we can prevent patients from having the cancer coming back and make a big impact. What we can't forget and what we're, behind the scenes, so, of course, big studies make it to plenaries at ASCO, et cetera, but you don't see all the sort of, single or combination centers, two centers, studies that we're trying to do to the most of our patients still have metastatic disease. And
Yeah,
after first line therapy starts working, these patients live longer and longer and they do better. And then in some ways, we're letting them down because they run out of options, of good options. And part of it is because patients they develop chemotherapy resistance, right? So most of the drugs that we use in the clinic are in combination with chemotherapy. And the paradigms that worked for certain subsets of lung cancer or breast cancer, where you can just give someone a pill and not worry about it, just doesn't work for our disease, as you know, because it's so aggressive and biologically different. So it grows faster. So what I'm interested in now is to try to develop a class of drugs that can use a radio tracer. So for example, if you have bone-only disease like Lawrence has, or bone predominant disease, but that has a biomarker that's specific for that disease, can you image it with a PET scan, like a PET scan that's specific for this cancer, similar to what they do, for example, in neuroendocrine tumors or in subsets of prostate cancer. And then if you have that target in that bone lesion or wherever else, you put a warhead on it and you do form of radioisotope therapy. So it's something called theranostics. Because the problem with our disease, after you live long enough with this disease, it becomes so morphed and difficult to target that if we go after each target the way that we did in lung cancer, the patient would be on 16 drugs. And even then, the response will be only 4 months long.
yeah,
And so we just need to kind of, in a way, nuke it. And that's what I think we will need to do for most of our patients. The problem, of course, with that is that you have to be able to get to a special center that can do that. You can't just do this at a small community hospital in non-tertiary cancer center. But hopefully we can overcome that too. We just need to first show that something works.
yeah, no, I think very good answer. And people on the call, don't forget to write in questions. You've got two real world experts here to answer questions for you. So feel
One
free.
holding a smoke detector. Um, I couldn't find a battery.
That's like the old college dorm move, just take the batteries out.
Exactly. I'm impressed with the with the Zoom noise cancellation because we don't hear any of that.
Well, I'm a little concerned because it's still beeping and I've taken it off the wall. I don't know what else to
What
do,
were
but
you making? Were you
what?
cooking? You were cooking, or why did this
No,
noise?
no, no. It's actually just run out of battery.
Oh, I see.
But it's normally hooked into the wall, so it's also got power. But you know, there are like 9 smoke. I have more smoke detectors than I have rooms.
Uh, Soon your phone will tell you something about it. Jordan, I'm going to come back to you on this one. This is a
Sure.
question from Susan in New York City. This is again about MSI, but it's a pretty good question. It's, will MSI high tumors respond to checkpoint inhibitors even if they're PD-L1 negative?
They should be able to. It's not a guarantee. That's the best answer I can give is that yes, they can. Can I guarantee it? But I
I
don't.
think the other question to consider is, and within MSI tumors, certainly there's a spectrum of response, and some of it is dependent on tumor mutational burden. So
Right.
I think the question is within MSI tumors, I think PD-L1, if you have an MSI tumor that's PD-L1 negative, it's very surprising, and I think some of it could be related to heterogeneity. In our disease, often we see MSI, not often, but often enough. If you do this often enough, you'll see it. MSI positive with MSI negative, or MSI clone with MSS clone next to each other within the same tumor. So, that's something we have to watch out for. So if you're getting a PD-L1 0 score, are you maybe testing the MSS adjacent sort of cells? But ultimately, I think looking at tumor mutational burden is very helpful to also predict the outcome. And that's the reason also why we use chemoimmunotherapy more often for this disease than, for example, in rectal or colon cancer.
Yeah, there's quite a humbling paper in colon cancer, spatial transcriptomic, where they map MSI and MSS cells, and in non-Lynch patients, every single tumor had regions of non-MMR deficient cancer. And I think you're totally right. In gastric cancer, it's a late event. It's a subclonal essentially by definition.
Hypermethylation, so.
Yeah.
Right.
Jordan, you've got some advice here in the chat about putting the smoke detector in the fridge to hide.
Susan, yeah, that's a good
Uh,
idea.
sounds like a
It's
voice
sitting
of
in my
experience.
briefcase right now. I like that idea, Susan.
Yes,
Anything to stop it from panicking my dog.
that is definitely a voice of experience from Susan. Yelena, while Jordan is, destroying his smoke detector in the background,
I
question
traded
from
it for a slice of turkey. That should make the dog happy.
nice. This question in the chat about combination of carboplatin and Taxol. So patient's father is a 77-year-old with GE junction adeno, signet ring cell features. It sounds like, and I don't know if this person is here to answer the question, but is this like stage 4 first chemo they're getting? But maybe talk about where do you think carboplatin and paclitaxel kind of falls in, since we really don't use it very much.
We, historically used it in combination with radiation for gastroesophageal adenocarcinoma, mostly esophageal adenocarcinoma. That's the so-called cross regimen that you may be hearing about over and over again. And we know that carbotaxel is somewhat active, but not as active as many of our other drugs, including fluoropyrimidines. So I think if your doctor is thinking of giving your dad carbotaxel, I would ask them why. I can tell you when I do it, and not infrequently, is in patients who progressed on FOLFOX nivolumab. So in first line setting, that progression of disease. And then in second line setting, we have a very straightforward regimen with paclitaxel ramucirumab, so Taxol Ram. But if a patient has a history of bleeding, or they have the risk of esophageal fistula, or have had a recent stent, I avoid ramucirumab because it can make things really scary for the patients and for myself. So in that case, if the patient is platinum sensitive in my mind, and my rules are relatively loose, in other words, they didn't progress while getting oxaliplatin still, and they're pretty functional, and I want to do a doublet therapy, and I think, again, a 77-year-old could be a very functional 77-year-old, but I can't give them RAM. That's the only time I use carbotaxol.
And
Otherwise, it's not a good first line regimen. We know that head to head, FOLFIRI or FOLFOX is better. And I hope no one's getting radiation. So that's hopefully not when they're using it either. But otherwise, in second line and selected patients, I think it's totally appropriate.
and then in the second line, how do you do it? Are you weekly carbotaxol, every 3 week carbo, weekly Taxol?
Usually we do every other week. I use, I do Taxol 70, and then carbo, maybe flat dose 250 or something like that.
Yep,
Again, it depends on patient's sort of functional status. Every 3 week dosing, I find in our patients is a bit much.
agree.
And 2 week on, 1 week off, also it's tough because of the platelets, and also, in second line study, in a second line setting, patients, it's tough for them to come in every week. And so again, we try to preserve functionality and quality of life and balance it with efficacy.
And it does sound like from the chat that this person is getting concurrent carbotaxol radiation, looks like in the follow-up. Jordan, I'm going to come to you with this one. You can pick if you'd rather explain TIL therapy as a broad concept, maybe versus compared to CAR T cells, or if you want to talk about different claudin cutoffs.
I'll go with a little bit on the TILs versus, I saw that TILs versus CAR T. So tumor infiltrating, you have different types of lymphocytes, and tumor infiltrating lymphocytes, you want the ones that actually kill the cancer as opposed to suppress the immune system. But that's different than CAR T. CAR T, what you're doing is you're taking out lymphocytes, you're drawing you're freezing the blood so that you get lymphocytes out. You do this chimeric antigen receptor. You use that to modify the genes of the lymphocytes so that they actually are trained to attack the cancer, and then you put them back in to let them kill the cancer. It's very different than the tumor infiltrating lymphocytes. It tends to have a little bit more in the way of side effects, and a little bit more of what we call I'm blanking on CRS, cytotoxic release syndrome, where you can get low blood pressure and things. But CAR Ts we've learned that they're much safer than we used to think. They're largely used in hematologic malignancies. They're still investigational in gastroesophageal cancer, as are TILs. This is all experimental therapy still. At Vanderbilt, we do all of our CAR T outpatient nowadays, now that we've learned how to manage this from an outpatient standpoint. So
yeah, and I'll mention at ASCO this year, in 2 weeks, we will see apparently the first randomized CAR T trial in gastric with the claudin CAR T is apparently positive for progression-free survival.
really? Okay,
Yes,
I didn't know that one.
we will find out. No, I've not seen the data either. Yelena, I'm going to come to you about this one. Maybe I'll broaden it a little bit to ask you how you think about biomarkers in the first line, prioritization. And then specifically, the question is, in someone who had essentially a total response to FOLFOX, but can't continue because of FOLFOX and presumably is claudin positive, like, do you see any role for like inserting claudin at this place?
Yeah, so I can tell you practically what I do. As claudin inhibitors are now approved, zolbetuximab first in class, and uh, we have patients who are still on first line therapy, and all of a sudden zolbetuximab gets approved, right? And many of them are switching now to 5-FU maintenance, or even 5-FU nivolumab, because they were high PD-L1 overexpressing. And we have data from the Armani study that showed that switching patients relatively early to second line therapy may be beneficial, meaning not waiting for frank radiographic, like rip-roaring progression before you change the treatment. And there were some design flaws with the study, and it's certainly not prime time to switch to something like toxic chemotherapy, like second line, whatever them to 5-FU from 5-FU nivolumab even sometimes relatively, early on before frank progression. Like so, and because they're technically in first line setting, I've not had, a couple of times I had to call insurance companies and sort of talk to them and convince them.
Yeah. Maybe I'll ask you a
Something
follow-up.
to
Oh,
consider.
sorry. Got cut off a little choppy. Sorry, go ahead.
That's something to do. I could tell that so I don't know how much of it you got. But in terms of prioritization of the biomarkers, is we go by factors that include response rate, survival, tolerance, and sort of risk to benefit ratio. And I think with that, I would, and I think Jordan summarized similarly prior, microsatellite instability is the most important because those patients can potentially be cured even in stage 4 setting with chemotherapy and immunotherapy. In most patients with MSI high gastric, I do combine that with chemo first, and then I de-escalate pretty quickly if there's a great response. HER2 is a critical biomarker because we have data from Keynote-811 showing that you could also have long-term disease suppression in stage 4 disease with chemotherapy, immunotherapy, and anti-HER2 therapy. So that's a critical biomarker. And if your doctor has not done MSI and HER2, you have to find a new doctor. The third one is PD-L1. PD-L1 is also important because it can give you a sense of where in the curve you belong in terms of likelihood of long-term cure, or not cure, but disease suppression. We're reporting 5-year survival rates in stage 4 global studies. So that's great to see. And then the fourth one is Claudin. So if you don't have MSI and you're not HER2 and you're not high PD-L1 or PD-L1 positive, Claudin inhibitors offer you an amazing opportunity for targeted therapy in first-line setting. It's a huge gap that it's filling. And zolbetuximab is just first in class. We have at least 3 different drugs that we're working on now that will be hopefully positive and available for patients. So MSI, HER2, PD-L1, and Claudin. And Claudin inhibitors are rough because they don't cause improvement in response rate, and they cause a lot of gastritis and nausea. So that's why I put Claudin inhibitors right now as number 4. But that list is always reevaluating, so we may have something better in a year, and I'll bump up the Claudin inhibitors. I'll keep you posted.
Maybe I'll ask you a quick follow-up question because this comes up a lot clinically. So, would you have a conceptual problem giving like Zolbe, Nevo, Folfox? Like, are you worried in particular about some synergistic side effects? Maybe just speak to if it was all available to you and the person was Claudin and PD-L1 positive, let's say, is it a combo you'd be interested? Because I get this question in clinic sometime,
I know.
PD-L1 2 and Claudin very positive, like can I just do both?
I worry about it in patients with primary tumor still in place. I think it can cause quite a bit of. So one thing that is underreported is the rate of gastritis actually associated with Claudin inhibitors, but also with if anti-PD-1 or immunotherapy works well, some of our patients do get quite a bit of esophagitis and gastritis. So I've seen some really ugly endoscopies from patients on combination therapies. I mean, hopefully no one's having dinner, but they look like raw steak. They're people's stomachs. So to do it outside of a clinical trial with a doctor who may not have a lot of experience with this, I probably wouldn't do it. Have I not done it? I've done it in a patient in adjuvant setting. This was a young patient who moved to be my patient from China, and he had very high level Claudin and PD-1, and his stomach was out. So we had very little to lose, but he had high risk disease, node positive disease. And he was self-pay, so we didn't have to worry about the insurance companies declining on this. So we used it, and it was not easy for him, even with that, despite the fact that he had a gastrectomy, he had quite a bit of nausea, but we got him through it. Kid, But overall, I would be a little hesitant to do it because I don't think the biology of clot inhibitors is the same as it is with anti-HER2 therapy, and there's less overlap.
Awesome. And, talking about raw steak, you're speaking my love language there.
I know, I know.
Um, Jordan, I'm going to come to you with this one from Amanda. It's a non-chemo question. This is I had my stomach removed due to being a CDH1 germline patient, presumably, and developed candy cane syndrome. I've had stents sealing off the blind limb. Maybe feel free to talk broadly about CDH1 if you want to, but specifically candy cane syndrome because that's the question.
Yeah, CDH1 definitely puts people more at risk for developing gastric cancer in their lifetime. It's something that you can inherit genetically. But the candy cane syndrome, I've seen this only a few times. I don't know if you guys have seen it much, but where the blind loop ends up being longer than expected. And I think what happens is during the surgery, the loop contracts and it looks shorter, and then after the surgery, it expands to its full length. You end up with this long blind loop, and patients get a lot of abdominal pain, nausea, discomfort, dyspepsia, and you can alleviate some of the symptoms with anti-nausea medications. You can use antispasmodics like Levsin and Bentyl, but in the long run, I don't know of a treatment that's worked other than cutting that blind loop.
Yeah.
Surgery has that we did it in the few patients I've had. I haven't had anybody in years with that. I remember that when I was all the way back in University of Wisconsin, I had a couple cases of that. I don't think I've had any since I moved to Vanderbilt. Now, admittedly, I don't see as many of the gastric cancers since we hired Mike Gibson, but I can't remember it because I also do panc, and that has the same surgery, the Roux-en-Y. But we did surgery on all those patients. In the long run, it was the thing that made the symptoms get better.
Yeah, sounds like a tough one. I can't say I have any more experience with that than that. Nothing really to add. Yelena, I'm going to come to you with this one. It's sort of continues on the MSI. Maybe you can just clarify this point from Lily. I'll read it. It's you mentioned the combination of chemo plus immuno for MSI, and there's a notation that, is there this relationship that MSI patients do worse with chemo? Maybe just clarify it a little bit.
Yeah, right. So I think in perioperative setting, what we're referring to is the study that looked at ECX chemotherapy, which is the MAGIC study, and patients who got chemotherapy versus went to surgery first did worse. What I am referring to is this phenomenon with gastric cancer where MSI tumors are not as sensitive to immunotherapy alone. And so we would definitely use immunotherapy, but the chemotherapy is designed not to just treat the MSI tumors, but also treat the potential MSS cancer cells, microsatellite stable cancer cells that are together with the microsatellite and stable. So you would definitely recommend immunotherapy in addition to chemotherapy. And then after first 2 months on chemotherapy or so, if there's a great response, we often de-escalate and stop chemotherapy either completely or stop one of the drugs. So it's nuanced approach because we know that anti-PD-1 therapy alone is just not enough probably in many of the patients.
Yeah. No, I think that clarifies it. That was a good question, but a good answer too. Jordan, I'm going to come to you with this one from Debbie in the chat. This is I think a question that a lot of us get. So basically, sounds like it boils down to, you know, neoadjuvant FLOT, but no response on pathology. What about the adjuvant FLOT? Do you do the same thing? Do you do something different? I know this is something we all see.
Yeah, it's something we all see, and I'd be hard pressed to continue FLOT. It's a fairly toxic regimen, and as we all know, we can't always give the same regimen in the post-operative setting. The difficult issue is what do you do instead of FLOT? It's not like we have a definitive answer for a another regimen, but you could consider it is. I don't know. You could, if they're PD-L1 high, you could consider immunotherapy. But there's not a lot of great data for things like FOLFIRI or some of the other regimens that we might be able to do. So, but it is hard to recommend continuing FLOT if there's been zero response
Yeah.
the preoperative.
Yeah, maybe Yelena, same question, and maybe comment on the sort of adjuvant ipi-nivo trial that, this Vestige study.
Yeah, I was really disappointed. We all thought that this study was a great idea. People basically who were non-responders to FLOT, meaning that there's a lot of positive lymph nodes and very little pathologic response, were randomized to continue FLOT or be switched to nivo-ipi. And these were IO naive patients. And surprisingly, nivo-ipi was actually detrimental. The survival curves were in favor of continuing FLOT. And, I think there's two caveats to this. You could say, well, nivo-ipi could potentially be toxic. And that's true, but I don't think that was it. I think the issue is that we're not very good at measuring so far the impact on micrometastatic disease that these chemos could have. And so the very logical decision would say there's very little response in the pathologic sample. Why would I continue the same treatment? Well, a lot of it has to do with also suppression of micrometastatic disease. And 2 cycles, 2 months of FLOT neoadjuvantly may just not be enough. And also, I think it's really hard to take it adjuvantly. So the way that I approach it is I decide based on what the patient's functional status is. And if they're still losing weight and aren't able to eat, we certainly don't give them FLOT. If they're, however, totally functional and feel great and, have lost no weight or very little weight and eating normally, then I give them FLOT, irrespective of what the pathology sample says. And if most people are somewhere in between, then I go with what Jordan says. And if they have a lot of positive lymph nodes, we typically try to get them FOLFOX nivolumab.
Maybe I'll flip the question to you, Jordan. What about the opposite scenario where someone has the rare, relatively uncommon scenario where someone has a complete pathologic response to FLOT? Are you still giving the adjuvant component?
Yeah, I'm not aware of data that suggests that you can get away without it, and said it's the same issue is that you're looking at the tumor that's out. Yelena's point about the micrometastatic disease, that's what you're really treating with the chemotherapy. And what we don't know is what's happened in the disease we don't see. And that's what's going to come back. Once that you've had the surgery, that tumor that was in your stomach can't possibly hurt you. It's the disease that was left behind in places we didn't know, and we don't know if that responded completely yet. So I would tend to favor completing the FLOT if you're in good enough shape to get it.
Yep, I think that's the party line I would agree with. And all right, we got maybe one more question in us, and I'm gonna try to not choke on my tongue, but let me see about this. All right, maybe this is a broad question. So Rob from Park City, Utah asks, if you're interested in getting a second opinion, when is the best time to do this? And Yelena, I'll just start with you broadly. Importance of.
I think you got to do it at diagnosis. I think the first person you see, and the second person you see may be the most impactful on your sort of outcomes and trajectory, because it's really heartbreaking sometimes when we see patients, and they've been on therapy for a long time, and things were done okay, but not, so it's hard to sort of piece it together and then rearrange things or, introduce clinical trials. I often recommend, and that's what the data suggests, is the first place you get treated is going to have a major impact on how likely you are to do well. And my advice would be, because people feel, and especially with the surgical consultations, and even with stage 4 disease, they get this bad news and they just want to act immediately. And in their mind, somehow, starting this Wednesday as opposed to next Wednesday is going to make a big difference, and it won't. I think you have to just understand what you're trying to accomplish and find the best team that can help you accomplish that. And it may be that you don't want to travel to a tertiary cancer center, but maybe after you meet with a team of experts, you realize you actually do want to go there because they give you peace of mind. It's your own life and it's your own cancer journey, but I think, getting all the information before you make that first decision is critical.
Yeah, Jordan.
Yeah, to put it simply, I think Yelena's right. The earlier, the better. And there is this belief, cancer is the scariest word in the English language. There's no word that you can find in our language that scares people more than this word. And so it gets people to react, but it's also not usually an emergency, it's an urgency. And during that urgency, you do have time. You do have time to seek out, to learn a little bit more. There may be a clinical trial option that you weren't aware of, or that your doctor, not because they're not good, but might not be aware of, that might be able to offer you an opportunity that you don't have otherwise. So to seek a second opinion, I always think the earlier the better. That way, that person who you've sought the opinion from is available throughout the course. If you don't go see them, if you don't stay with them, they may still be available. So that, if the second line therapy, if you're metastatic, you need a second line therapy, they may have a trial, or even third line or fourth line. I do investigational drug therapy. So I do the very first phase 1 trials, and those can offer opportunities you might not get otherwise. And being tuned into that person might be helpful. And of course, like Yelena said, you might want to switch. You might feel more comfortable with a different team. You never know.
Yeah, I think I would only add that, if you're here on this webinar, you're already doing another important piece, which is educating yourself so you can advocate for yourself and, learn from others and learn from people like the experts we have here. But I want to be respectful of everybody's time. Thank you to Jordan. Thank you to Yelena. Thank you to everybody for showing up. We will do this again sometime soon, and have a good week.
And thank you to the person with the refrigerator suggestion.
Yes.
Have a good one, everyone. Thanks, Sam. Great job.
Bye.
Yeah, good
Take
night.
care.